Malam ya.
Oke, silakan.
Baik, Assalamualaikum warahmatullahi wabarakatuh. Selamat malam kepada para speaker, para peserta, dan juga pada moderator, dan juga kepada Dr. Diki Armen Hanafi, selaku Presiden INAHLS 2020. Selamat datang di webinar seri INAHLS 2020. Sesuai schedule, malam hari ini kita akan membahas tentang catheter ablation of ventricular tachycardia, dan juga akan kita sharing beberapa case dari ischemic VT ablation. Langsung saja saya perkenalkan untuk moderator kita pada malam hari ini, Dr. Anggia C. Lubis, SPJP Konsultan. Saat ini beliau aktif sebagai konsultan IP di Rumah Sakit Adam Malik, Medan, Sumatera Utara. Kepada Dr. Anggia, saya persilakan dengan segala hormat.
Thank you. Assalamualaikum warahmatullahi wabarakatuh. And good evening, everyone. To all audience and all INAHLS members, thank you for joining us again this week. And tonight we are going to have two excellent speakers who will give some talks about ischemic VT ablation. So our first speaker will be Dr. Fa Po Cheng from Taipei Veterans General Hospital. His current position is at Heart Rhythm Center and Division of Cardiology, Department of Internal Medicine in Taipei Veterans General Hospital, and also assistant professor in National Yang-Ming University. So tonight, Dr. Fapo will give some talks about catheter ablation of ventricular tachycardia in ischemic heart disease. I know it's a bit complex for most of the audience, but I'm really sure that the insight that Dr. Fapo will present today will give lots of new insights for all audience. Dr. Fapo, the time is yours.
Hello.
Hello, Dr. Fapo.
Yeah. Sorry for some problem of the connection. So my website has some problem. So I would like to reconnect it to get it done.
So after Dr. Fapo present his presentation, our next speaker is the one and only Dr. Sunu Raharjo from National Heart Center. I think all of the audience knows him very well. He works currently at the National Cardiac Center, Harapan Kita Hospital, and also teaching at the University of Indonesia. Hi, Dr. Sunu, how are you?
Oh, hello. Assalamualaikum, Dr. Anggia, and good evening, all of the colleagues who joined this meeting. Nice to see you all.
Nice to see you. I think we have already a huge amount of participants joining us today. Everyone is very excited about tonight. We are still waiting for Dr. Fapo to prepare his slides. And I think it's very common that we have
Hello. Can I be here clearly? So sorry for some problem with my camera. So I'm not sure. So could everyone hear hear me clearly?
Yes, we can hear, Dr. Vapo.
Yeah. Sorry that I have some problem with my camera, so I did not show my photos currently. But I think if it's no problem, that I will try to present currently. So today I would like to talk about catheter ablation of the ventricular tachycardia in ischemic cardiomyopathy, the current practice that we have. And this is my outline that I would like to separate in a few aspects, including the ventricular substrate of the ischemic VT, and also the ablation strategy, and also the endpoint. So first of all, that the majority of the ischemic cardiomyopathy belongs to reentrant, but we also never forget that around 7% of the ischemic VT that could belongs to the trigger inactivity. So the most important is that the majority of the VT still belongs to the scar related, and some of them probably that will not involve in the scar, but will involve of the nearby Purkinje systems. Sometimes we also need to use some image systems to identify that some patients have the mixture of the ischemic and also the non-ischemic cardiomyopathy at the same time. So this is a very beautiful paper long time ago that we started to explore the energy of ischemic substrate, that the surgeons help us to try to dissect the scar of the endocardium. After that dissect the endocardium, that put the 64 hole of the microelectrodes within the endocardium, he could record it a very tiny lead potentials. Currently, we consider it a very good size for target. And when they try to use the surgical method to remove the scar, and that actually the lead potentials was gone. And you could see that originally the far field potentials become a very big near field potentials at the same time. And they just place the scar at the same place and put the 64 poles, try to record the scar area. And it also found that the lead potentials were scarred as well. You could see that the far field potentials was the same as before the removal of the scar. So this is also very beautiful animal models from Rapan, and they use the animal model to create the ischemic substrate. And this is beautiful that you could see that the isthmus was located here. We always consider that the ischemic channels will be very superficial. However, in this demonstration, you could see that the ischemic isthmus is very deeper inside. And when we just place the ablation catheters on this area and with the energy delivery, and the tachycardia was terminated soon. So when we try to separate the lead potentials, we just try to categorize the lead potential into lead potentials defined by within the 200 milliseconds, and or the very lead potential, which was out of the QRS onset more than the 200 milliseconds. So this is the distribution of the lead potential. You can see that in the borderline or a dense scar, the majority of the ischemic substrate have more lead potentials and or very lead potentials comparing with the non-ischemic substrates, even in the endocardium or the epicardium. And also this is the electrogram distribution. You can see that the majority of the lead potentials for ischemic substrate was located within the endocardium. And some of the lead potentials we could record it at the epicardium that will be that as much as comparing with the endocardium. So which means that probably the epicardial substrate, especially when we comparing with the non-ischemic substrates, would be more important compared with ischemic substrates. So there are several ablation strategies that we have before we perform the ablations, we always need to have the image, try to delineate the substrate that we have interest. You could use the T, try to see the wall motion, where is the full wall motion site. And also we need to observe whether that we have some problem of the mitral regurgitation or aortic regurgitation, and also whether that the substrate was protected by the valve, close the pulmonary muscle. And also T is a very useful tool, not only approaches for the wall motion, but also try to delineate the storm burst and also cardiac MRIs. Just as the presentation before, we have the several cases that we can already identify the scar, especially for ischemic scar or the non-ischemic scar, and also the intramural scar that belongs to the channels that we have. And some group also use the CT try to delineate the channels as well. Of course, we need the 3D mapping system. Currently, you always have that. And the mapping caster, more and more advantage given from the advancement from the company and using the high density mapping materials. And also we will have the ablation casters using the concave force, try to give us whether we have a good concave or not. This is the illustration of the one of the ischemic VT that we have. To understand where we should ablate, and you can see that the VT have the channel here and have the the outer loop here, and it sits at here. So, however, this VT will be very weird for a majority of the EP doctors when you see this tracing, and you will totally have no idea about where the channel is, because you always identify that looks like here will be the channel, but actually the true channels will be a very limited area close to here. So this is the reality of the situation that we have, because we always have a very extensive scar. A lot of the bystander or the outer loop delay conductions, especially within the very extensive outer loop area that we have, which was also published recently in the circulation, mentioned about the importance of the outer loop conduction velocities could result in a slow conduction of the VT. Given that we appreciate that the publication very top, and very happy that we also participated in a part of the study. Actually, that the majority of the VT isthmus will be the three-dimensional architectures, and which means that probably we could see part of the endo and with the epicardial breakthrough, or we have some part of the epicardial reentrance with part of the circuit could be visualized by the endocardium, or some of the patients we have the mid myocardial reentrance that could not be identified from both the endocardium and epicardial mapping at the same time. So this is the distribution of the VT three-dimensional architecture for the VT isthmus. You can see that not only for a non-ischemic VT, but also for ischemic VT, the majority of the VT isthmus will be the three-dimensional in architecture, even though that previous study showing that more left potentials could be identified from the endocardium. But we also found that the majority of the VT, even that we always consider that the ischemic VT will majorly involved in the endocardium. However, in this study, we also found that the majority of VT, for those involved in the endocardium, the majority of the VT could also involved in the epicardium at the same time, which means that the majority of the VT, even for the ischemic VT, could have the three-dimensional architecture. Now, techniques have been presented for ablation of the VT, and I didn't want to go through those strategies at the same time, as well for the old technologies that we have, including the linear show lines, targeting the conducting channels and their potentials. And also that is the very fundamental hypothesis that we use for entrainment. First of all, that I want to talk about the entrainments, but this is a very beautiful paper published by the Air Enters group. they use the animal model and delineate that the old strategies that we delineate the isthmus, actually we could overestimate the size of the isthmus, because that when we just try to pace from the outside of the isthmus or the other side, that we could also get a very good returning cycle, because that usually the entrance and or the exit will be the slowest conduction region comparing with the other part of the isthmus. And also a lot of the pitfalls could occur when we do the entrainment. This is some of the examples published from Rod, and he also tried to show when we just try to do the entrainment, sometimes we could also have the decremental properties of the isthmus. We could account for those interpretations. And the majority of the VT before the achievement, before the availability of the high density mapping, sometimes we could use the pace mapping, and it could also be used for currently, which means that we could get a very higher pace mapping score at the exit side. However, if we pass at the entrance or the mid of the isthmus, which means that probably we could have the fusion of the antidromic and also dromic conductions, which will result in the wrong interpretations and a fusion of the QRS morphologies that were not similar to the VT morphologies. This is also a very old strategies just try to pace in at the scar area and also lab potential area. We could get a very long stimulus to a QRS onset. And if this is more than 80 milliseconds, which means that it will have the higher probabilistic of the isthmus. Future that I would like to talk the advancement of the possible channels, because we have identified some of the continuous lab potentials, and we always try to delineate this one, consider that this is the potential channels activated from this side to this side. And this is the very beautiful publication from Database Group, showing that even we have the map of VT and we try to identify that one and result in a non-inducibility at the end, if we did not try to delineate all the lab potentials, actually we could result in a worse outcome compared with those with the VT was non-inducible and the lab potential was completely eliminated. So therefore, a lot of the lab potential, the subtle modification strategies have been provided, some published from Europe and some published from the United States, even using the just like this paper from published by the DBS, and using the endocardial epicardial substrate homogenization. And this is from Wendy, one of my friends, and also use the core isolation where in the non-capture of within the scar. And this is the dechanneling, and also this is the lab potential from the pacing, and try to eliminate all the lava that we have. However, we always need to understand that the interconnection channels is more complex than we imagine, because just like in these figures, when we just try to consider that this channel conducted to this one, and if we try to ablate it from the proximal channels that the potentials conducted to the distal channel that we have, and how about the outcome? You can see the complete elimination could only be achieved in 36 of the patient. However, that almost to be the 20% of the channels, even we try to eliminate the proximal part, that there will be no changes of the distal part of the leg activities. And also this is another paper published by another group, and just trying to show that even we get a lot of the leg potentials and also the supporting channels, the majority of the channels did not support the VT reentry, and the majority of the channels that we have belongs to was not belongs to the channel that responsible for the VT reentry circuit. So in the end, that some paper also published about using the normal strategies with the signal processing, try to identify some late potential, the fractionation potentials, especially for a septal scar, that we have the abnormal electrograms. Some fractionation signals was buried inside the near field potentials within the myocardium, which could be eliminated in this scar. And this is also the similar methodologies using the Hilbert formal transformation from our group, try to eliminate the scar that we have. And this is the most recent publication, the novel technologies that help us to more identify about the VT mechanisms. Because long time ago, we always consider that the latest potentials behind the onset of the QRS, behind the offset of the QRS, will be the most of the interest that we have. However, this paper is very interesting. It just tries to separate it in the activation into the 8 isochrones equally. And they just try to separate it into different isochrones and found that the majority of VT actually could be terminated in the lesser or the less second part of the isochrones, which means that the majority of the VT was not located, the majority of the major circuit was not located at the latest part of the ventricular activation. Then next time, and they found that usually when we always understand that the entrance and also the exit usually will have the relatively slowest conduction velocities. So this paper just try to using the science reason, try to identify this, or what we call to be the deceleration zone, defined a very short area with the crowding of the isochrone regions, which will be always to be the site that we have interest. And they just try to ablate it based on these strategies, and they always found that, especially for some patients, if we could identify that the deceleration zone, try to target that, we could result in a better outcome, not only for ischemic, but also for non-ischemic, and always reach a very relative, very better outcome in the future. And Enter et al. Also published a feature study from the multi-center, try to showing that sometimes we could also try to pace from different sides because the deceleration sometimes could occur. Just depends on the wavefront propagations. And when we just try to pace from the opposite sides of the wavefront propagation, the surrounding the star, we could delineate more isochrone regions, help us to do more substrate modification and result in a better outcome at the end. So the finalist that I would like to talk about the endpoint of the catheterization of the substrate VT. The best way, especially for the high-risk patient, not only eliminate the index VT, but the major process of ablation is try to reach the non-inducibility of the index VT at the end. And also, this is the very beautiful paper from two groups. One is the very famous paper about the SMART-V published by the NEJM, and talk about the prospective randomized study talking about the benefit of the ablation comparing to control group, and also the VTEC study also proved that when we try to do the ischemic VT ablation, actually we could reach a better outcome, especially for the recurrence of the VT. I think that a lot of the electrophysiology will be afraid about the LV ejection and also the functional test of the patient before ablation, because we are afraid that the patient will be too weird to perform the VT ablation. But in this study, from a multi-center collaboration, we could find that even for ejection fraction was less than 30, we could still reach have the higher outcome compared with those without the VT recurrence. And also, no matter which kind of the functional test that you have, you still could reach a better outcome after ablation. So this is my conclusion, that the ventricular tachycardia in the ischemic substrate or the non-ischemic substrate are totally different, owing to the different abnormal substrate that we have, and also the ejection ground will be also heterogeneous that will result in a different outcome that we have. And the ablation strategy of the ischemic VT should be individualized, and more evidence prove us that the substrate modification could result in a better outcome. However, that real study also showing that we could reach the substrate modification within a very short period of time, just target the dissociation zone, and also reach a similar outcome compared with the previous strategies. And also that the non-inducibility VT usually will be the gold standard that we target, and also additional substrate modification targeting the lab potentials even through the scar homogenization, the lava elimination, scar deteriorating, and also the core isolation could always result in a better outcome based on the multi-center study. Thank you.
Thank you, Dr. Fapo, for the excellent thoughts to start our evening. It provides a very good introduction for our meeting tonight and give us a lot of insights about how complex the mapping, the ablation, and the endpoint of the VT ablation in ischemic heart disease. Now we can move on. I think we can combine between Dr. Fapo presentation and the next presentation of Dr. Sunu, one of the brightest talent in Indonesia, who will share of some of his cases in ischemic VT ablation. Dr. Sunu, the time is yours. Thank you, Dr. Sunu.
Thank you, Dr. Anggia. Thank you, Dr. Fapo. I really enjoy your presentations, and let me share my slide. Okay, could you see my slide?
Yes, we can see it clearly.
Okay. Yeah, good evening, all colleagues and senior and friends. Today, I would like to share two cases of VT ablations, and we are fortunate today that we have Dr. Fapo and all other seniors who join this meeting so that we can discuss about ischemic VT ablations. Yeah, this is just the numbers of VT or PVC ablation in our center in Harapan Kita. And in 2019, we have only 5 VT ablations, but in 2020, currently we have 7. So if we calculate the percentages, this is kind of 3% and now 6%. The numbers are not many because this is still a challenging and emerging field, as has been shown by Dr. Fapo. Dear colleague, so if we have a patient with VT, presentation with VT, first we have to see if the patient have underlying heart disease or not. And now we are talking about this VT with structural heart disease and specifically underlying of ischemia. And this is there are many approach that we could use to do the VT ablation, and Dr. Fapo has explained this very clearly. And this is my approach myself. So if we have the patient with a scar-related VT, so I have to see whether during the EP study or during the process of ablation, the VT is inducible or not inducible. If the VT inducible, then we could map during the VT and do the entrainment map and ablation the targeting critical isthmus, and of course, finally to see whether the VT is still inducible or not. However, if we have the VT which is intolerable or the hemodynamic is unstable, we have to do cardioversions and then isochronal map during sinus rhythm. And we have 2 cases. I hope I could finish 2 cases. So the first is with tolerable sustained VT, and another one is unstable VT.
Dr. Sunu, sorry to interrupt.
Yes.
Can you put the slide on full screen, please?
Oh, this is not full screen?
Not full screen here yet, because...
Oh, sorry. This one?
Yes, it's perfect.
Okay, thank you. Sorry. Thank you, Dr. Anggia. So I just want to repeat that the reason why the reason why for in fact will cause the VT. This is the figure that has been explained by Dr. Fapo, and this is the normal conduction across the ventricular myocardium, the normal ventricular myocardium. However, if we have the scar in our myocardium due to infarct, for example, and we will see that there is a block of the conductions. So we will see that some of the conduction will go through the channel, and we will see this kind of electrogram during the electrophysiology study. And this is the terminology used to see and to look for when we are doing the VT, ischemic VT ablation. So the isthmus, the exit, outer loop, entrance, and also bystander. I will start with the first case. 48 years old gentleman referred to Harapan Kita Hospital due to recurrent VT from the center, despite on the Concord and Amidoran. The ejection fraction is 41% and have hypokinetic in the inferior and interseptal area. And in the CAT show normal LAD and LCX, but there is a CTO-RCA. We have done the surgical conference and the decision is conservative. However, the VT still persists. So this is the CTO in the RCA area. This is the underlying sinus rhythm ECG. You can see there is a Q wave in the inferior lid and also in the septal regions. And this is the VT morphology. We could see that the morphology is a left bundle branch block. And we could see that there is a inferior lid negative in the inferior lid and positive in the 1N AVL. Can I have the polling? Hamid? Dr. Naga, may I have a polling? Only 2 polling? Yeah. So based on this 12 lead ECG, I will go back to the slide, the previous slide. Yeah. Yeah. So based on this 12 lead ECG, where is the possible origin or exit of the VT? RV apex, RV free wall, LV basal infraseptal, LV apicoinfraseptal, or LV free wall, please. Okay, can I see the result? Well, almost distributed evenly in the A, B, C, D. So how can we, because this is the first step when we are planning to do the VT ablations, where is the possible location or the circuit of the VT? So can I close this? Okay. This is the publication in JCI 2000 and I think 2014 of 17, I forgot. But this show that when you have the VT with LBBB, ischemic VT with left bundle branch block morphology, almost for sure that the origin will be from the septal area. And it depends on the location of the direction of the inferior lid and lid 1 and AVL, whether it is negative or positive. In our case, we have the left bundle branch block morphology and negative in lid inferior, on the inferior lid, positive in lid 1 and AVL, and negative in AVR. So possibly this is a septal, mid-septal, based on this criteria. And this is another criteria. So this is left bundle branch block morphology with increasing rate air wave progression pattern. Yeah, this is the detailed algorithm to see the location of the VT, but this is kind of the general one. So if you have inferior lid negative or inferior lid positive, so in our case negative, so this is manifestation inferior, and then one is negative, in our case positive, so this must be from the septal, and apical and basal area determined by the transition in the precordial lead. And we did this LV-graphy, and we could see here that in this area of this basal to mid inferior, we could see that the movement of the myocardium is less compared to the other regions, and also in this basal area. So we prepared with this InSight precision cardiac mapping system, and then duodecapolar mapping catheter, flexibility irrigating catheter, and Agilis steerable sheath, and we use both antegrade and retrograde approach. And these are the parameters of electrogram we use to determine whether the electrogram on the myocardium in this particular area is normal or kind of potential as a reentrant circuit, like the split potential or isolated lead potential or fractionated lead potential. And this is the voltage map that we have. We could see that in the free wall, completely normal, and here in the septal, in the apex to the mid, we still see the magenta show normal tissue, while the scar determined or showed in the gray area, and those between gray and the red, yellow, those area, the area with low local abnormal ventricular activity. And sometimes we need to adjust. Usually we use this 1.5 to 0.5 as a value to see whether the tissue is normal or scar. So below 0.5 is scar, but sometimes we need to adjust. I use 0.25 to see more clear the channel that may involve in the VT circuit. And after, this is the first step that I usually do when I do the substrate VT ablations. So after I have this substrate of the VT, I do the VT inductions, and as you can see here, that only with the 2 extra stimulus, we could see the VT easily inducible, sustained. And this is same with the VT clinical VT morphology. Since the VT is very stable, we are fortunate and we could do the activation mapping of the VT, and we could see here that the earliest activation of the VT is around this mid to basal inferior of the left ventricle. This is a view of RAO, and this is from this posterolateral, yeah. And yeah, this is show here clearly that this is very early. And we did the entrainment mapping, and this show that the post-spacing interval is same with the tachycardia cycle length, and the direct the distance between stimuli to QRS, this is 50, and also the EGM to QRS is also 50. So this is concealed entrainment with the possible. So we can see also the trail of lead morphology are very similar. So this part is the pacing, and this is the VT. And if it is less than 30%, we could see that this is the exit side of the VT. So the entrainment mapping we did in this area. So this is the notch area, the kind of white ball is the place that we locate the entrainment locations. And when we put the duodecapolar catheter, we could clearly see that in those areas, we have so many fractionated lead potential surrounding this concealed those area. So this is again showing the importance of this area as a circuit of the VT. And during the VT, we also consider the mid-diastolic potential. Therefore, we did the ablation in those area, like this part. Yeah, those dot, the green dot and the yellow dot are the place that we did the ablations. And sorry, yeah. And after this, we tried to, yeah, we're really optimistic that, oh, we could eliminate the VT already. Unfortunately, after we did all this ablation, we still could induce the VT. And we observed that in the RV septal site, we also could see those kind of local abnormal ventricular activity, and we could map those re-inducible VT in the RV site, and this is also quite early. So we did additional ablation in the RV septum, and if we combine, this is the LV, and this is the RV. So this is really the circuit in the septal region of the mid-basal left and right ventricle. And this is the image of the catheter ablation position. This is the Agilis. And afterward, the VT terminate during the RFA and no more inducible with even more aggressive stimulations. And the second case I would like to share, this is refer to our center, and then this is have a kind of stemma anterior in November 2019, and he already took the beta blocker and Concord and amiodarone, but still the VT present unstable. That's why he always, when he came to a hospital, always have a DC shock. And the ejection fraction, you can see from this echo, is 40 to 45% using Simpson. And the movement in this area, so you could see the basal area is quite good, but more mid to apical area, we could see that the movement is less compared to those other area. And we did coronary angiography, LAD stent patent, and LCX, we could see a kind of 50% lesion in the LCX, and RCA normal, but small vessel. This are the ECG that we have during the patient came to our clinic. Because, we could see this is the sinus bit and this is the PVC. And I want to give another polling. Although this is not the VT, but we could see this is the bigeminal PVC. With this morphology, where is the possible location of this PVC on the VT? Okay, another polling, please. So based on this 12 lead KRAS ECG, where is the possible origin or exit of the VT? Dr. Anggia, could you see the ECG?
Yes, Dr. Suno, it's clear here.
Okay, thank you. Oh, very long. How long the time for polling?
I've set at 1 minute. I can close it now if you want.
Oh, Kingsley. Oh, no, okay, it's okay. Thank you. Okay, can I see the result? Well, again, almost distribute evenly in those areas. So if we look at this morphology, this is a right bundle branch block morphology. Most likely the origin are from the left ventricle, and the inferior lead negative, so probably somewhere from the inferior, but you can see also in the transitions is start from V3 to V6, or negative, so kind of the apical area. So this is, and one in AVL is positive, so apicoseptal area of the left ventricle. Yeah, this is another approach that we could use to see the origin of the VT. Inferior lead negative, and then one NFL in our case is positive, so probably not from the lateral, but the vice versa from the septal area. So in this case, we did the ablation using a retrograde approach, and this is the ECG of the sinus rhythm. We could see in the septal area, and the Q wave in the septal area. And these are the VT substrate. This from the aerial view, you could see. So this area with the scar and the channel, and this inferior is normal, and the free wall also kind of normal tissue compared to the septal and apical area. And the VT is easily usable even only using one extra bit. And we can see here the VT morphology are similar with the PVC. And yeah, initially this is stable, but only a few minutes. So we do in activation mapping because it is stable in the few minutes, but not long. After that, this VT transform to another morphology like this, which is more rapid and hemodynamically unstable. So initially we did the cardioversions, but still, after the first cardioversion, even changed to another morphology, and we did and very rapid the VT, and we did another DC shock, and finally we can get the sinus rhythm back. And during those mapping, so after those rhythm back to the sinus rhythm, we do another substrate mapping because we have not completed it yet. But many VT morphology appear and unstable. That's why we rely only on the sinus rhythm using this asynchronous late activation mapping. And you can see here, this is the kind of the late potential. And if we look at the propagation of this late potential, we could see as has been shown by Dr. Vapo. I think we need to get his advice to see where is actually the circuit of the channel. But we could see here around this area is really late. And if, yeah, this correlated with this area of between scar and abnormal active region or low voltage zone area. And if we also merge or synchronize this area of the ELAM and the earliest activated during VT, these are also connect or similar. With, you can see the electrogram here is very, very late and also long. This is 220 milliseconds, and this is also very early in the activation mapping in the similar area. So we did ablation in those area, and we also adding additional ablation in other part to show the lava local abnormal ventricular activity. And yeah, afterwards we could see that even with the more aggressive pacing, only this is non-sustained VT and then no inducible VT. This is the description of the location of the catheter ablations. And after 1 month, we observed that in the ICD, the patient has been implanted ICD, there is no VT or shock. Ladies and gentlemen, dear colleagues, so as a take-home message, I would like to mention that an understanding of ECG morphology provide important information in the predictions of ventricular arrhythmia origin, including scar-related VT. Radiofrequency catheter ablation has gained an increasingly prominent role in the management of ventricular arrhythmia, and multiple mapping approaches are necessary to define appropriate target ablation for scar-related VT. Thank you for your attention. Thank you, Dr. Angga.
Thank you, Dr. Sunu. Wonderful presentations. I think we just saw 2 excellent cases from Dr. Sunu. In case 1, he approached the VT from both sides, from the left and from the right sides of the ventricle. And in case 2, I think we can learn that singular circuit can have different morphologies of KRS. I think that's some good points that we can learn from the cases that Dr. Sunu just shared. Dr. Vapo, would you mind to give some comment about both of the cases?
Yeah, thank you, Sunu. I think it's a very, there are very fantastic cases for both of these 2 cases, and I think this is the, yeah, usually the inferior substrate, especially for the inferior substrate involving the inferior and also the septal scar, are the the ones that we didn't want to have, because it usually could have the possibility that we need to do the bipolar ablations, and some patients that we need to use the epicardial approaches to target the cross regions, because that it's a protected region. Sometimes could be protected by the pulmonary muscle, and sometimes it just located the cross regions in between the right ventricle and the left ventricle, just as what you're showing in the first case. And the most interesting thing for me is the first case, because it looks like to be the negative concordance with the LBB morphologies from the V1 to V5, which was supposed to be usually that we will consider that it will be very close to the apical region. But
exactly. Yes.
But from your map, it seems to the early sides seems to coming from, especially for the left side, seems to be coming from the relatively to be a little bit more basal, right?
Yeah. So mid to basal area of the septal. Yeah. So I was also initially thought that it is something from apex, but actually it is not, Dr. Favo.
Yeah. So would you like to show the tracing or show the electrograms that when you try to map from the left side?
Yeah, sure. May I have okay. I could share. So this is.
So I mean that for the activation map, I remember you have
activation map. Okay.
Yeah, some entrainment and also the activation from just like no that the next one, the next
This is the entrainment.
Just stay in the entrainment. Just stay in the entrainment.
In the entrainment, okay.
Yeah, this is the very good examples try to showing that I personally thought that this is the very the signals that will be very close to the I'm not sure because I didn't try to measure that, but I personally think that it will be very close to I'm not sure that it's captured or not, but probably need to measure in detail, because the cycle length is different. How about the patient cycle length? It will be the 390, right?
Yeah, 390. So and the PT cycle length is 430. I believe this is a capture. I believe this is capture, Dr. Favo.
Yeah. I also agree with you, but for my personally, that I would like to consider that you are pacing at the side that is very close to the exit, but
exit to the exit, yes.
Very close to exit, but actually it's a manifest and trend, because you can see that for the lead 1 and also the lead 2, that a little bit difference is comparing with the QRS width and also the morphologies.
I can show you the next slide, the 12 leads. I feel this is a kind of very similar, yeah.
Yeah, I think it's almost very close to exit, but still belongs to the manifest and trend, right? Because you can see that you get the R wave of the V2 and also the V1 and also the V3, V4s, but you lost of the R wave in your pacing.
Exactly.
So
yes.
I think it's a very good example. Just try to demonstrate the importance of the intramural substrate. But you get a very good returning cycle, which means you are at the location just similar to my previous talk about that when you try to entrain from the side that is very close to exit, you could get a very good returning cycle based on the a previous published criteria, which means that we are very close to the epicenter, but still located at the outer loop. So it also proved that that's why finally you could get a successful ablation from the right, because because this is the intramural substrate.
Indeed,
So,
yeah. I think the circuit is between the LV and RV, yeah, Dr. Fafo, yeah.
Yeah. I totally agree with you. So that morphology is very similar. It's a very beautiful case.
Thank you, Dr. Fafo.
Yeah. But both cases are very beautiful, I think. Congratulations.
Thank you, Dr. Because of your teaching.
Dr. Fafo, would you mind to share some tips about deep intramural ablations?
Yeah, usually that actually this is a very very beautiful paper also published recently from the Enters group, and because we talked about this issue before, and I think this is the issue that we always consider, that how deep that we could penetrate the energy to the scar tissue that we have.
Yeah.
And that paper is from the animal study published probably, I remember to be the Circ-A or the Harriet or the JEP, just like the top 3 papers that I already purchased. And that paper just talked about there's no criteria. It means that that's the scar tissue, just like an insulation. That's we totally have no idea about how the energy could get into the tissue. So it means that probably that we could get more energy. So you could consider that, for example, just like AF ablation, you could set it to be the 40 watts or 50 watts. You consider we created a transmural regions if we appreciate it. But the main consideration in the VT is that once if we have scar, then we target the leg potentials, especially for epicardial substrate that we have, sometimes could be confounded by the epicardial fat. And we totally have no idea about how many energies that we can deliver to the tissue, because we totally have no idea about the depth of the fat. And it also has been published as well that some ischemic substrate that could not be eliminated owing to the protected by the fat tissues that was formed in the process of the ischemic substrate formation. So my personal opinion for the intramural isthmus, if we really consider that is the intramural, or we consider that is the isthmus that cannot be eliminated from the superficial, that I always try to set to be the 35 to the 40 to 45 watt. Just try to because we have a very terrible experience. We get a skin pop that the patient sent to the operation room for a surgical repairment. Even we set to be 35 watts, because sometimes during the process of the remodeling, that the wall will be thinner compared with the normal tissue. So I usually have 35 watts, but if I can success, usually in this kind of situation, under the assistance of the eyes, I will try to use the hepcidin the next step, because we also know that the energy could not penetrate to the tissue deeper inside. Is owing to the water crowding the tip of the irrigated catheter, which means that the energy could not penetrate owing to impedance that barriers. Therefore, I would like to change to the hepcidin as the next step if I cannot get success. And then, if I cannot success as the next step, I would like to do the bipolar ablation.
Bipolar ablation, yes.
Yeah, if I consider that is to be the intramural. However, if we consider that is more close to epicardium, based on the information from the eyes or the cardiac MRI, that I would already go through to epicardium as the next step.
All right, thank you very clear explanation, Dr. Fapo. And you also mentioned earlier about the endpoint, Paulo Della Bella endpoint. I think he's getting more aggressive on VT ablation. He's aiming for clinical and also non-clinical ventricular arrhythmias. What is your what's your approach on the endpoint?
Yeah, of course that even in our that we always I think the majority of the EP lab always follow the steps that we always hope that we could induce even for a non-sustained VT that cannot be inducible at the end. That will be a very fantastic outcome that we have, because based on previous publication also mentioned about the possibility that even at the end of the procedure, if we have inducible non-sustained VT in the future, we still have the higher chance to get the recurrence. Probably that is owing to the immature lesion or owing to the transient inhibition of the isthmus. So which means that the endpoint that I personally will be appreciated I could have even for the totally have the non-sustained VT that could not be inducible. That would be very fantastic thing that I have. However, that I will set another criteria, especially for some patient with a very extensive scar. If I cannot achieve, or if I even could achieve the total substrate modification, but I still could have non-sustained VT or non-clinical sustained VT that could be induced, that I will just try to keep the patient under antiarrhythmic drug. If the patient is tolerable, then I will try to see the outcome and wait and see if the patient still have the recurrence. I will put on for a second procedure to try to target the VT that we have interest. But if the patient have no recurrence, because we still have a lot of the VT, around 60% of the patient actually could get rid of the VT recurrence if the VT is non-inducible, if the clinical VT is non-inducible, but still have some VT that was inducible at the end. So which means that we didn't need to do a lot of the VT, additional VT ablation, especially for very fragile patients at the first time.
Yeah.
That's my personal opinion for that for this point.
Thank you, Dr. Fapo. Excellent. I think we have come to the end of our meeting for today. Thank you again, Dr. Fapo, for your excellent presentations and for your time for joining in HRS for tonight.
Yeah, thank you.
Thank you, Dr. Fapo, and thank you also for Dr. Sunu, who has excellent presentations, much better, much more entertaining than the way Arsenal play lately. Thank you for all audience. Good night and Assalamualaikum warahmatullahi wabarakatuh.
Thank you. Waalaikumsalam warahmatullahi. Thank you,
Terima kasih kami ucapkan kepada
Thank
Dr.
you.
Anggia Lubis sebagai moderator. Terima kasih kepada Dr. Sunu atas waktu dan ilmu yang sangat bermanfaat pada malam hari ini. And also thank you to Dr. Fapo for sharing more knowledge for us tonight. Selanjutnya saya meminta kesediaan Dr. Agung Fabian SPJP untuk menyampaikan sedikit pengantar pada malam hari ini. Kepada Dr. Agung, saya persilakan dengan segala hormat.
Terima kasih kepada Dr. Farah. Assalamualaikum warahmatullahi wabarakatuh. Di akhir sesi hari ini saya akan sedikit aja memberikan pengumuman bahwa untuk penutupan webinar INAHRS pada bulan Desember nanti akan ada door prize yang diundi. Kemudian yang kedua akan ada pemilihan peserta yang paling banyak online, paling banyak mengikuti webinar, dan peserta yang paling banyak memberikan pertanyaan. Jadi di akhir-akhir seri webinar series INAHRS ini kami mohon para peserta tetap setia setiap hari Jumat untuk mengikuti webinar, dan jangan lupa ada door prize pada akhir penutupan nanti pada bulan Desember 2020. Terima kasih Dr. Farah, saya kembalikan.
Terima kasih kepada Dr. Agung Fabian SPJP Konsultan. Jangan lupa para peserta untuk webinar minggu depan dapat dilihat on screen masing-masing peserta. Jangan lupa untuk selalu update webinar INAHLS untuk memperdalam ilmu aritmia khususnya di Indonesia. Selalu update sosial media kita karena setiap minggunya akan ada update link untuk webinar selanjutnya. Terima kasih kepada para partisipan. Sampai bertemu minggu depan. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you for the support, Kingsley, and all of the EBIT team. And
Thank you. Thank you. Take care. Stay safe.
Thank you, Kingsley.
Thanks, Doc. Take care.